It's a real pleasure talking here and sharing some of my clinical experience with the audience. And I think it's a very exciting time to work in radiofrequency, a modality specific in the US, which really gained a lot of traction in recent years due to some really exciting publications, but also the understanding of precisely what Dr. Patel just mentioned about really the importance of the correct treatment, the correct technique, as well as really maximizing lesion size. So I want to talk in the next couple of slides about why should we maximize lesion size, what's the science behind, and how could we potentially do that in the future. Next slide. So if we're thinking about healthcare demand on each practitioner these days, we really have a combination of needs here, a combination of needs in terms of course, best outcomes, longevity of outcomes, and time, as well as healthcare resources. So how much is actually a procedure costing? Now, already in 2014, Cosman looked at factors what affect radiofrequency heat lesioning size and how that can influence then the degree and likelihood of better outcomes. So of course, lesion size will increase our interventional success. It will decrease complications if we do it in the appropriate setting. We have to address the number of required lesions, which triggers into procedural time. We have to address the radiation exposure, secondary procedure time, but also by placement of needles. And we want and need to address the intra and post-procedural pain, which is an important aspect of radiofrequency. How does it come that we very often, unfortunately, see great outcomes with diagnostic blocks? But then when we actually go ahead and do the same approach with a radiofrequency probe, radiofrequency treatment, we sometimes do not see the same similar outcome, either no response, which does happen, unfortunately, or really a shorter response. And in the consensus statement, Nilesh mentioned already, which is a very important paper to read, is already stating that one of the areas we can improve is to decreasing our technical failure rate by increasing lesion size. This should be a general accepted concept. I want to direct these now to the right of the slide here. And this is very simple, but a very efficient and very good to understand x-rays here. And this is from Dr. Patel himself. So what we see here is contrast material right in the area where the medial branch is running, right in the groove between the SAP and the transfer process. And we see just 0.3 ml of contrast. Now, this should be the amount you use for your diagnostic blocks. This should respond then, or did not respond in failures to outcome of the diagnostic block. Now, we see that this is a fairly large lesion we need to cover. This is a fairly large area where potentially the nerve can run, which we address with a 0.3 cc of lidocaine or local anesthetic to block it. In clinical practice, we need to reduce the technical failures. And technical failures can have some addressable solutions. Some are easier to solve, some are not so easy. And here we have the three main reasons why patients fail to respond to RF treatment. Of course, it can be a misdiagnosis that needs to be determined by better criteria, selection criteria, blocks, and really identifying the appropriate patient. We do have sometimes poor selection of patients, honestly, almost beyond our control. And that is a larger degree to psychosocial factors, depression, somatization. We can have patients with secondary gain issues involved in legal process, personal injury cases, these type of things. And sometimes just the greater disease burden. Specifically in the US, we're dealing with a large, still ongoing epidemic of opioid disuse and addiction here. So that is certainly not an easy task to change. What we can do change and are changing currently is the technical failures. And as Nilesh also mentioned already, the technical failures in how do we actually address the nerves, how can we target the nerves? And missing the nerve is probably part of why patients are not responding after great diagnostic blocks to RF treatment. So enhancing the lesion size with the appropriate technology or technique to, bring your needle parallel to the median branch is definitely something we can control and should control. Ideally, RFA should last at least 12 months. In the US, we're able by Medicare standard to repeat RF treatments after 6 months, but technically, ideally, we should have that. Now, many authors recognize that, unfortunately, we do not necessarily always see that longevity of RF, even if it potentially work in the beginning. And Cohen sees this potentially as a problem of or a problem of lesion sizes we have, and as a solution to maximizing lesion size. Chapman also points out that part of the problem most likely relates to the problem that we're not coagulating the entire nerve. So as, just point areas of the nerve or, part of the nerve. And that gives, the nerve the ability to reinnovate and reintegrate fairly quickly after the burn. Excellent. So this is again an important picture here as we trying from a technical aspect to parallel or place the needles parallel to the running nerve. So we don't want to come perpendicular just with the tip. Therefore, as we are otherwise may miss the nerve. Now, as we saw in Dr. Patel's X-ray slides here, the area where these nerves run can vary. And I think that's one of the problems we do see. Even if we have the best parallel technique, we simply, if we do not have large enough lesion size, we may not capture the nerves as it runs above or below actually our needle tract. And therefore, the margin of error we have to treat the medial branch is low, is really small. So we need to maximize our ability to capture a larger area where these nerves run so we can address it in a parallel placement as well as in a larger lesion size. Now, in summary here, and again, this has been studied and published now in the last recent years, why should we maximize lesion size is really to optimize our treatment outcomes and the longevity. So we want to have a larger lesion coverage, we want to have longer pain relief, and we want to obtain a higher sustainability of the outcomes here.